Hello, hi. My name's Gita. I'm one of the F2s currently working at Lister. So I've been asked to give you a bit of an overview about what it means to discharge a patient and what you guys have to know and to do when discharging a patient. Okay, so it's going to be a really short video, but things that we're going to cover is who and when to discharge, TTOs and discharge letters, what to include, what to write, working with GPs, and I'm just going to run through some common outpatient scenarios. Okay, so first of all, discharging patients. So the first thing to note is that F1s can't make the decision to discharge a patient. It is not an F1-led decision. It's always led by a senior. So on the wards, typically consultants will want to see patients who are nearing discharge. And when you're in AMU or A&E, clerking a patient, it will always be run by a senior who will typically come and see and make that decision. But once the decision has been made, it's your responsibility to ensure that the necessary paperwork is done. So by that, I mean TTOs and discharge letters. Just as a side note, I didn't know this until quite a few months into my F1, but TTO stands for to take out. Some people say TTA, meaning to take away. But yeah, that's just a bit of a side note, really. Okay, so this is probably the most important slide of the whole thing. So really take this in if you don't take anything else in. So consultants will go around, or seniors will go around and say, this patient can go home today. Things that you need to be thinking in your head from your perspective are, what is the diagnosis? I know this sounds really silly, but what did we actually treat in this patient, okay? Because you're the one that's going to be writing it in the discharge letter, you're going to be arranging follow-up, this is going to guide what's going through your head, okay? So if needs be, clarify it on the ward round at the time, what exactly did we treat? What is going on with this patient, okay? Is this patient still on oxygen? If they are, do they need home oxygen? Do we need to wean them before they can go? What's the plan, okay? Is this a surgical patient? And by that, I mean, do they need extended VTE prophylaxis? So quite often with like the orthopedic patients, for example, they go home with a month or 6 weeks of dalteparin. Even the medical patients, if they've had a PE or something, they might need extended VTE. So again, you're the one that's going to be writing the TTOs. So you need to have it clear in your head as to what the plan is for that. Have we reviewed the drug chart? So this is useful in terms of changes to medications. So what medication did the patient come in with, and what are we sending them home with? Is it the same? Have we made any changes? Have we made any additions? Again, if this needs clarifying, clarify it on the ward round. It's so much easier than later on in the day when you're trying to figure it out by yourself. Just ask your senior at the time, and it makes a world of difference. What is this patient's follow-up plan? A very quick question to the consultant. Do you want to see them in clinic? Do they need to be seen in clinic? Things like that. And if so, when? So how urgent is the follow-up? Do they need district nurses? So district nurses aren't strictly in your domain. The nursing staff will do the referral to the district nurses. The only way it will come under your radar is if a prescription is necessary. So if a patient, for example, is going home on insulin and the district nurses are going to come in and give the insulin, then you will need to do a prescription for that. And there's a separate form for district nurse prescriptions. The nurses usually know where that form is. But that just needs to float through your head just so you have a rough idea. How is this person getting home? Again, not strictly in your domain, but it's good to have in your mind somewhere. The nurses or the social and discharge team usually book transport if it's needed, but it's good that you've just got this going through your head. Do they have a package of care? So I'm sure you will have seen it by now, but essentially on the wards, quite often consultants or registrars will say this person is medically fit or medically optimized, but that doesn't always correlate to when they actually go home. Because quite often they are awaiting a package of care. Either they need a new package of care or they need their package of care increasing. Whatever the reason is, you need to be thinking in your head, are we awaiting a package of care? Is it ready? Is, this patient going home feasible today? And does the family need to be updated? So that's not just in terms of family members picking relatives up, but that's also in terms of, have they been updated as to what's been going on? Do they understand what's going to happen when the patient goes home? Follow up, things like that. So just make sure everybody that the patient wants to be updated is updated. Okay. Doctor, have you done the TTOs? So this is a phrase that you will hear time and time again. I cannot express how much nicer it is for you in your day-to-day job if you have been able to prep TTOs earlier. Okay, everyone will like you more, you'll be happier, you'll just get a better peace of mind. It's not always possible, definitely not always possible, but where you can, try and do it early. I think the key thing to remember with TTOs is that you are the first part in a very long chain. Okay, so you're the one that initiates it, but then it's usually checked by the ward pharmacist, has to go down to pharmacy, reviewed by another pharmacist, dispensed by a different one. The nurses then have to go and collect it from pharmacy, or it has to come up. It's a very long chain, and you start that chain off. So if you're delayed, it delays the whole process. So I tend to get TTOs done as soon as I can, really. And use the ward pharmacist. The pharmacists are so nice at Lister, and they're so helpful. They understand that when we first start out, we're not used to writing so many prescriptions, and we often need a hand, and it's completely okay to ask them. They're happy to help, and they're very useful, and it saves both of you time versus you doing it wrong and them having to correct it if you just actually ask them at the beginning. So in terms of using the ward pharmacist, actually, when I was making this talk, I asked some of the pharmacists what they would want us to know. And they've actually given me a few slides. So shout out to Mark Brooks, the pharmacist who gave me these slides. So the first point they want you to know is about control drugs. So control drugs need to be, the amount needs to be written in words and figures. So I'll just explain what I mean. So when you go onto Lorenzo and you search for a drug, it will come up, and can you see the little purple box there, little pink square that says CD in it? So that means it's a control drug. So that's automatically alerting you to it. So you don't need to know off the top of your head what are the control drugs. Morphine is, probably one that comes into your head, but things like gabapentin are control drugs as well. That's why it's written here. And essentially it means you just need to calculate how much they would need for the 2-week supply, and then that's how much you supply. So looking at this screenshot here, you can see in additional comments, it is written, please supply 28 in words and figures. Okay, so it's written out in full. So just make sure you write that, because that saves a lot of fuss with your control drugs. So write that out. End of life medication. So this is on the Knowledge Centre. If you just type in anticipatory, it comes up. And I actually have a screenshot of this on my phone. It's very helpful. Basically, when you're doing it on the TTO, it tells you, you can see on the right hand side here, it tells you the drug, how much you supply, and the strength that you need to supply. So when you're selecting which strength on Lorenzo, it's useful to have that to hand, and you always supply 5 ampules. But that's all on the Knowledge Centre, so have a look through that as well. And then the final slide from pharmacy is that they want you to remember anticoagulants and insulin. So if you think of like the main body of the drug chart, you've got all the drugs in the middle, but actually at the end of the drug chart, you have the insulin, and at the beginning, you have the anticoagulants. So where the VTE is where it will say things like apixaban and warfarin. Make sure you've looked at those and you've included those on the TTO. I've definitely missed them out before, and I know lots of people have. It's just because of the position they are on the drug chart. So just keep a conscious mind about looking at those. And the final thing from them is they want you just to make sure that you've recorded all the allergies. So when you first go onto your discharge letter, it will prompt you to say, does this patient have any allergies? You literally read the front of the drug chart and you type in what it says on the front of the drug chart if they do have any allergies. Okay, so that's TTOs. So essentially, TTOs on the medication side of things, and then the other part that you have to do is the actual discharge letter. TTOs, like I said, are vital to be done early because it's such a long chain of events, and you're the starting point of that. But actually with discharge letters, there's slightly less rush because you're more in control of it. It's you that's writing it. So it's basically down to you. Saying that, although there is less rush, it is important that the discharge letter is done by the time the patient is discharged. Okay, so it can be done later on, but it still needs to be done on the day of discharge at the very latest. Okay, so in terms of discharge letters, you need to think, who is seeing this? Okay, so the obvious person is the GP, okay, because you are literally sending the letter to the GP. But other people that see these letters are other secondary and tertiary care physicians. So for example, when you're clerking patients into ED or AMU or SAU, wherever it is, you will typically look back at old discharge letters. And you'll use information like past medical history, what they came in with. If there's anything notable on examination, you'll want to know if that was there from a previous admission. So you'll use that information. And the final people to think about is the patients, okay? Patients read their discharge letters. Be very cautious about what you write in the discharge letter. It needs to marry up with what you've said to the patient, okay? I'm thinking particularly about more sensitive diagnoses. Your opinion and things like that, just be cautious about that in discharge letters, especially when it's not been discussed with the patient, okay? So keep it very factual, just to save any issues. Okay, so once you're thinking, right, who is this going to? This then guides what information is relevant and what information needs to go into the discharge letter. It's important to emphasize that everybody does their discharge letter very differently. And the more discharge letters you see, the more you'll realize how different they all are. Some of us start it with a courtesy, dear doctor or dear colleague. That's absolutely fine. Not a necessity, but absolutely fine. And then generally we go for like a prose type style. So this 79-year-old lady came in with shortness of breath, was diagnosed with X, treated with X, Y, and Z, has been discharged home with a plan to follow up, etc., etc. Okay, but the key points there are you've said what they've come in with, okay, what you've done for them, what investigations is part of what you've done for them, how you've treated them, and then what your plan is for the future, okay? Those are sort of the key points that you have to hit. It is a fine balance between keeping it succinct and relevant, but also making sure you include all the necessary information. The way to think about it is think about, what use is this sentence to somebody, and anything that stands out should be mentioned as well. Okay, I'm thinking things like unusual examination findings that perhaps someone would want to look back and see, did they always have that heart murmur? Things like that is useful. But it's just so difficult to explain because it varies patient to patient. But I think at the beginning, people tend to write longer discharge letters, and then usually with time that gets more succinct. That's absolutely fine to progress like that. But keep bearing in mind that you want the relevant information still there. But equally, people don't want to read pages and pages of a discharge letter. You don't need to do things like copying long, CT scan reports. If you can write in a one-line summary what that CT report meant, okay? GPs can look up investigations on ICE just like we can, so they don't need full long blood test results or reports. They can see it if they want to. And the same, obviously, when a patient comes in, we can just look it up on ICE or on PACS. So it doesn't need to be over heavy, okay? But just something to bear in mind. Okay, so the next bit I'm going to talk about is working with GPs. So the other thing to mention is follow-up on your discharge letters. So I'm going to talk more about forms of follow-up a bit later on, but in terms of GP follow-up, you need to understand that writing something like, please repeat use and ease, is pointless. Please repeat use and ease. If AKI has resolved, restart furosemide 40 milligrams. If not, please consider reviewing in 2 weeks. That is a succinct line to the GP that tells them exactly what needs to be done and explains what to do with those results. So it's fine to say, please can you do this, but you need to say what you will do with that information. Okay. And another point to mention is just about the courtesy in the way that you write letters. So remember that as an F1 or an F2 writing these letters, you're often speaking to a more senior clinician. Okay. So it's without sounding like a mother, please and thank yous go a long way. Okay. Please, can you kindly repeat these blood tests, or please consider a repeat scan. They are senior clinicians. They do know as much, if not a lot more than us. So it's never a demanding, do this, do that tone. They are very stretched in primary care. So just be aware of that. If you're ever in any doubt about any of the follow-up plans that you have in place and you think, I don't feel overly happy giving the GP so much to do, just call them. Call them and say, look, we've got one of your patients in. We're looking to send them home. I would like to do this. Would you be able to help? Okay. I had a case last week where we were deciding about, we wanted a chest x-ray in 6 weeks time, and we were deciding whether I should book it or the GP should book it or how that worked. I rang the GP, I explained the situation, and he was more than happy to book it and follow it up. So just give them a call. And the other thing is, GPs can give you information when patients first come in terms of past medical history, why was certain medication stopped, what's this patient's baseline, things like that. GPs can be very useful for. So please don't be afraid to phone GPs. People often don't think to do it, but it is a very useful resource. Okay. Fine. So this actually my final scenario really is about outpatient follow-up. So I've sort of racked my brain and I've come up with these 6 possible options as to where a patient can go to. I suppose you could argue the 7th option is no follow-up. So ambulatory care and OPAT. So OPAT is outpatient antibiotic therapy. So for these, it basically, the key is in the name, okay? The patient needs to be ambulatory, okay? They need to be mobile. They need to be able to get themselves to the clinic. There is a form. I'll show you the form. So this is the form that you fill in. It's on the Knowledge Centre. This is the form that you'll fill in, and essentially you fill in the patient details and what they need to be seen for and how long. Okay, and there's also one for OPAT. It's a very similar form, also on the Knowledge Centre. So that's ambulatory care. The second one is clinic follow-up. So clinics for any specialties, obviously, that they have a follow-up process. So that you'll hear the term ex-ward bandied about at Lister. So an ex-ward referral, this is an ex-ward form. Sorry, not very high tech. I've just screenshotted a lot of these, but so the ex-ward referral, you basically put the patient label and you say which team you're from and which team you want to refer to. So, you know, for example, acute medicine is your team, specialty that you want to refer to is cardiology in 6 weeks time. And then on the back of that form, it's just got an empty box where you just write a little spiel, okay? And it just helps them guide when they're in clinic. So that's relatively straightforward. You can then give that form to the ward clerk, who will then sort out the appointment. GP follow-up. So we've talked about GP follow-up. You just write it in the box that says GP follow-up in the discharge letter, and that letter goes to the GP and they understand what to do. and just reiterating to make it clear and concise and make sure they know what they need to do or consider doing. The fourth one is anticoagulation clinic. So anyone that you start on an anticoagulation needs to go, or an anticoagulant needs to go to anticoagulation clinic. Again, form on the Knowledge Centre, you fill it in, very straightforward form, and they will follow them up. There's a clinic at Lister and QE2, depending on where the patient lives, and quite often I like to follow up the anticoagulation clinic referral just with a phone call. It does say on the form, if referring for a NOAC, please ring the number. So just give them a call and they just put the patient on the system. Very simple form, and it's also got an email address that you scan the referral to and send to that email, but the email is on the form, so that's very straightforward. The same with TWAT clinic. So the TWAT clinic, if I'm not mistaken, runs out of the urology nurse's office on level 7. It's on 7B. So again, it's a form that you can find on Knowledge Centre. You can fill it in. I've dropped it off on 7B before, or you can just scan it and email it to them. So TWAC, sorry, I should have said, is trial without a catheter. So it's patients that you're sending home with a catheter, but who you want the catheter to come out eventually. So your aim is to try and get the catheter to come out. It's not a long-term one. So if a patient has a catheter, you need to be thinking, is this long-term? Do I want it to come out? Do I want them to go to a clinic where they'll take out the catheter? And then the final one is referral to a tertiary centre. So especially at Lister, we often refer to Addenbrooke's, sometimes Queen Square, UCLH. And again, that process will happen when the patient is an inpatient and you've discussed with these teams, but make a note of it on the discharge letter that you've sorted out care at said tertiary centre, okay? There's no set way to do it. It depends on the unit that you're referring to and what you're referring for, but that's a completely different talk, which someone can show you. But essentially, just make sure it's written on the discharge letter what you've done. Okay, so that's the outpatient scenarios. Just a note to say, when I say on the Knowledge Centre, so if you literally click your homepage when you go on, you'll see this screen. And if you click documents and policies, and then comes up with a search bar, and that's how you can search for any of the forms that I've mentioned. And this is, again, just the ambulatory care and the ex-ward forms that you've already seen. Okay, so outpatient scenarios, important. Tell the patient the plan. It sounds really, really simple, but with everything going on, it's quite easy to forget. But just make sure they know the plan. Okay, and then document the plan clearly on the discharge letter and put as much detail as you know. If you know the patient is going to be seen in ambulatory care at 11 a.m. on Friday, write that, okay? Put that down. Tell the patient your appointment is at 11 on Friday, okay? You can't put too much detail in terms of the follow-up plan on the letter, okay? There's no such thing. Yeah. Okay, so this is my final slide. Thank you for bearing with me. It was slightly longer than I anticipated, but I know I rabbit on a bit. But to summarise safe discharges, TTO and letter need to be done, okay? You know how to write these, you know what to include, and you know to do them in a timely manner. Make sure the MDT are aware, okay? So you would have had a meeting that day, some sort of, discussion with physios, the nurses, the OTs, the social. Make sure everybody's on the same page. This patient is going home today, okay? Transport if needed. Again, like I say, discharge team nurses will usually do, but make sure that that has been booked. Make sure the patient and family are aware that they're going home today, okay? Make sure the package of care has been started by the social team if needed. Quite often patients need to be home by a certain time to be there for their package of care to start. Again, nursing staff, very, very on the ball with this, very good at doing it, but just have it in the back of your mind, okay? The discharge is everybody's responsibility. It's a group effort. And then finally, appropriate follow-up in place. So check on the ward round, what follow-up needs to be done, and how long, what sort of length of time does this follow-up need to be done in, and document it clearly in the letter, and then arrange it using those various referral forms. Okay, thank you. So that's a very brief talk on discharging patients. Sorry if I've not covered anything that you wanted, but please feel free to contact me, email me. I'm often around the hospital. If you see me, just ask a question. More than happy to be contacted. Okay, thank you.